Awesome. Good deal. So today, let's talk about our Polish warm blood gelding. His name is Whisper. He was 19 years old and he is a dressage horse, no question mark. He is a dressage horse.
Looks like a foundered horse.
Yeah, well, he's not. Well, he's not. So he presented October 24 with the history of running into a gate. And he was initially treated as a shoulder hematoma. I'm presenting you here pictures of the left shoulder, where on physical examination, we can see muscle atrophy of the infraspinatus and the supraspinatus muscle. We can see the prominent scapula of the shoulder, prominent spine of the scapula, and we can see the prominent point of the shoulder on the left view. This is a video, and I know that on Zoom, videos are a little bit of a tricky situation, so I'm gonna describe it to you in case you don't see it. He has a 2 out of 5 left front lameness. I'm gonna play it again. 2 out of 5 left front lameness. He's in a circle to the right. We can see the left front lameness when he's circling to the right. We can also observe the awesome technician who is running him. Fantastic model, great physical fitness. We're gonna go from behind. I'm gonna say that on my side. And he's also from behind. We can also see that he's obviously lame on the left front. So, in summary, dynamic examination showed that he was 2 out of 5 left front. He had a slight short cranial face of the stride and is more evident on the circle to the right than it is on the circle to the left. These are the radiograph of the shoulder. Obviously the left shoulder on both sides. This is the ultrasound of the supraspinatus and the infraspinatus muscle. We can see that the ultrasound has what I learned this weekend, a lot of real estate in the bottom. Probably should have done this ultrasound at the depth of about 6 centimeters or so. And the reason here that there's so much space between the scapula and the bottom is obviously because there's a lot of atrophy of that muscle. So I probably should have make a smaller image. You can see there's not muscle fibers. It looks like a tendon. That muscle looks like a tendon rather than an actual muscle, because they're not obviously not muscle fibers. This is a ultrasound of the shoulder, where we can see some remodeling on the proximal humerus. And I don't have a pointer here, but the proximal humerus is on the left, and the scapula is proximal humerus on the right, scapula is on the left. And there's a slight increase of fluid in the scapulohumeral joint. Please remind me to put arrows for the next one. I'm going to put arrows in here. So, in conclusion, the horse had a suprascapular neuropathy and had shoulder instability due to trauma. Medical management included a shoulder injection, ultrasound-guided shoulder injection of Kenalog HA and amikacin, and we're going to talk a little bit more about that. And on November 17, he went for decompression of the suprascapular nerve. He went for surgery. And after surgery, the rehab period included hand walking, a combination of hand walking with obviously wound care, etc., plus anti-inflammatories and antibiotics. Then he went to rehabilitation, which included shockwave therapy at 1,000 shocks at the surgical site. Excuse me, 1,000 shocks. Around the surgical site and the neck for 3 times. He received magna wave in the surgical site and also around the neck area. Received laser therapy, underwater treadmill. The prognosis for this lesion is good for survival and fair for performance. This is a follow-up after about a month. So in about a month, our lameness went from 2 out of 5 to 1 out of 5. So we were happy with that. And this is 4 months later. You can still see the swinging, but he was actually being able to be ridden and serve some purpose at a lower level. His muscle atrophy continued, never fully recovered, but he was serviceably sound. Right. Oh, I'm trying to stop it when the muscle atrophy is, so you can see it. Right there. Right there, you can see that there is some muscle atrophy going on. Well, the client was happy. She rides him several times a week, and no successful outcome according to the writer, right? So let's talk a little bit about this disease. This is a suprascapular nerve injury, and the diagnosis is very pathognomonic. No, you can diagnose this with your eyes. You don't need ultrasound. You don't need radiograph. You just look at it, and voila, that's your best diagnosis. Radiograph and ultrasound are good for documentation, obviously, documentation of the atrophy and of the supraspinatus and the infraspinatus. And the synovial effusion of the scapula is due to the shoulder instability that happens because obviously the shoulder muscles are not providing the stability that they need to provide. The supraspinatus and the infraspinatus muscles provide shoulder stability to the scapulohumeral joint. The ultrasound looks like this because right when the muscle starts atrophying and the muscle fibers start atrophying, there is intramuscular connective tissue. And the intramuscular connective tissue looks like a tendon. For that, we call that neurogenic muscle atrophy. The bone surface of this particular horse looked pretty normal. The peripheral nerves are they're susceptible to trauma, obviously, and they are, when this happens, there is a denervation, and there are 3 types of, we'll talk a little bit more in the pathogenesis of this disease. But basically, the atrophy of these muscles happen because the motor branches of the nerve is affected, no? This is relatively uncommon. This is a relatively uncommon problem. However, probably all of us have seen it. There is not necessarily a breed, gender predisposition. And trauma is by far the most frequent cause of this problem. And obviously the location, and we're going to talk a little bit about the location of this nerve. Why is this nerve predisposed to this problem? So this nerve is going to come from the brachial plexus, and the brachial plexus come from the cervical vertebra, and it's going to come from 5, 6, and 7. The musculoskeletal, the musculocutaneous nerve is going to come from 5, 6, and 7 cervicals, which if you look in the screen, it's going to give you cervical nerve 6, 7, and 8. So the formula to figure out what the nerve is 1 after the cervical. So if it comes from cervical, from C6, from C5, C6, then that's cervical nerve 6. C6, C7, cervical nerve 7, C7, C8, cervical nerve 8. So that's where our suprascapular nerve comes, and there are 3 degrees of genital injuries: neuropraxia, axonotmesis, and neuromesis. To summarize it, neuropraxia is just a malcompression. Axonotmesis, where there is crushing of the axon, but we still don't have a severe cut in the nerve. And neuromesis is when there is basically a denervation, no? And that follows atrophy of the muscle and shoulder instability, because there is no muscle providing stability for that scapulohumeral joint. Just to give you an idea what the nerve look like, or what the location of the nerve look like. On the left, we're going to see the lateral side. It goes on there's a blue line on the lateral aspect of the scapula. Then on the medial side, you can see how it crosses over the dorsal aspect of the scapula. And then it gives you the branches, obviously, to the suprascapular nerve, suprascapular muscle, and the infrascapular, and the supraspinatus, and the supraspinatus, and the infraspinatus. But the reason it's so predisposed is because if you look on the left side of the screen, there is a blue arrow, there's a blue line on the bottom part, on the bottom left, and that's a not to scale area, but so you have an idea where it crosses. So when you have trauma pinching that nerve with the scapula, that provides a area of major damage to the nerve. And then the idea of the surgeon is to remove that piece of the scapula to then allow that nerve to expand, to decompress, etc. So that's the idea of when they do the surgery. Obviously, Dr. Stachak, he proposed that surgical treatment that included removing that notch from the scapula. And it's like a wedge that they remove from that cranial border of the scapula, and to relieve the pressure, with the idea that the nerve renervates, all the nerve grows back together, and we have a happy life after that. There is a proposed conservative treatment combination, which is one of the ones that we use, which is where Miller and Drescher, they injected those shoulders with intra-articular corticosteroids, and they saw some improvement. I'm not sure I saw the improvement that they saw. However, there's no question about it that these horses develop some sort of shoulder pain because of the shoulder instability. So my hypothesis was that the shoulder injections help a little bit because this horse develops secondary pain due to the shoulder instability, not necessarily that we were treating the swinging or that we were treating anything related to the etiology of the disease. So there's some literature about it, and I would say significant literature about shoulder problems, but there's not a whole lot of cases that could explain or could help us out, have a quick resolution for this. Basically, no one has been able to point out what works totally best. We have a really good handle on explaining why there's atrophy of the muscle, why the disease happens, etc. But it is a neuromuscular disease, and there's no question about it that every time we have motor nerve damage, it's going to be significantly difficult to try to have a very good prediction of outcome on these cases. However, a lot of these cases were definitely serviceably sound, and if they were treated very aggressively and within 2 weeks the muscle was starting to come back, the prognosis was significantly better. And that's my case.
The outcome of that those situations, you have to be very aggressive at the beginning of the treatment with anti-inflammatories to try to help the area to avoid the inflammation to crush the nerve. I think that's one of the most, and being successful in a few cases from any shoulder trauma. I used to do the MSO for 3 days. I do and massage and improve a lot.
So Dr. Lichoa uses IVD MSO right away and massage on any shoulder trauma to increase success of these shoulder injuries.
I have a case inside this year. There was 5 out of 5 legs. She came from Kentucky and she had some trauma in the shoulder, very bad trauma. And we take care of her and she went to the 7 at soul.
So there's a horse that came from Kentucky that what he's saying, if you guys didn't hear, similar history, that got trauma, got treated, went and got sold, and that's definitely what they report in this.
The aggressiveness of the case, the treatment beginning, I think, is very important.
That's definitely what they report in these cases, and this particular horse got treated very aggressively too. That's I think for me, the most difficult part to determine at the very beginning of the trauma is which one of these three is the problem. If it's neuropraxia, axonomesis, or neuromesis. I think if we would be able to find out which one of these, then we will be able to predict the prognosis significantly better. Comments online.
The only addition that I have is the acupuncture group has they've got some good information on electroacupuncture in this area, some really good cases. Now, the case that I managed, they didn't really want to spend any money on it, so I didn't get the chance to do a whole lot. I would have been interested to see if it's as profound as what the acupuncture group describes.
Yeah, I am definitely not an expert on acupuncture, but this horse had acupuncture, as you can see here in the screen. Dr. Shona Canwell did acupuncture to death, and I should probably, other than this screen, I'm gonna write that down significantly more. Yes, this horse had acupuncture, had even had electroacupuncture. I mean, this, to us, in my opinion, this horse had everything. This was a no limit horse. So this horse had I need to make it more clear in the presentation, had every freaking therapy that we read or thought, and acupuncture was definitely one of them. And they even brought a massage therapist, right, to massage him 3 times a week, the acupuncture 3 times a week, and then what else did I say? And all the rehab therapies that you have.
I-
Laser, vibration plate, love, what else?
I
else
couldn't
did
tell from the video, but it never got to the point where the scapula actually separated from the attachment of the horse where, you know, during weight bearing, did it?
No,
Okay.
no. The more he became was a 2 out of 5, and I think that that's what helped him a lot. Obviously, he was a 5 out of 5 when, I mean, at the farm, when they saw him, then they gave him the anti-inflammatories quickly, and when he got to the clinic, he was already a 2 out of 5. Yeah.
Good.
Question,
Question over here.
why when you say he was laying to the right in circle, you didn't do the right, to the left?
I don't have a, probably lost it.
But do you remember, because if the lesion was on the left side, it would be worse on the left.
Oh, the question is, why is this horse, why I didn't video the horse going to the left? That was definitely, let me see if I video this horse to the left. There's a high chance if
Got
if it's
tired.
not, or I lost the damn video. I lost the, I did not put this video here. Obviously, I lost the video. I need to find it. Thank you. So he was more named towards the right because the only biomechanical explanation that I can come up with that is that when a horse lands on the left, turning towards the right, is a more abnormal attitude for that shoulder. That's the only explanation that I could have. And anyone on you guys can have a different explanation. Why is this horse? Why some of these shoulder lameness are worse to the opposite leg?
I think if you go to the straight on, you'll see that he places that limb under his center line. The video of the straight on.
This one over here.
Well, yeah, when he comes towards you, I believe. See how far under the center line he moves his left front limb.
Mm-hmm.
I think when he goes on the circle to the outside, that puts that limb, like you said, too far abaxial, and that shoulder already has instability in it. Whereas if he's jogging to the left, that actually increases the stability because he's kind of leaning over the shoulder and drawing it in towards his chest.
Yeah. That's definitely my guess. And we see sometimes also these with suspensory desmitis, this proximal suspensory desmitis, where they go on the outside.
Worse on the outside circle, yeah.
Chewing wise, we always made sure that he got shot flat. That's about the most we did, and we also made sure that we didn't do anything super special, honestly, with the chewing. We just put him flat, and we took radiograph and made sure that the breakover was exactly at the tip of the P3. So the breakover being just exactly at the point, and that's it. We didn't do anything. We didn't try to do anything fancy other than proper balance. Dependent on, as a podiatrist, what would you do in cases like this, chewing wise? Anything different that you recommend?
No, nothing at all. I don't know that the breakover needs to be all the way back under the tip of P3, but during the rehab phase, because it might actually it might actually, if you challenge the deep flexor a little bit, it might actually help the rehabilitation, like you're trying to achieve a little bit in the aqua tread,
Like you mean
just
extending
challenging the protraction of the limb.
yeah, extending the
But-
cranial face, trying to extend the cranial face of the stride on purpose type of thing.
Yeah, but I nothing crazy at all. I'd just show them flat.
Mhm. Good. All right, questions, comments? We'll put arrows here for the next presentation, and I have to find a circle to the left. Let's see where the hell that video is.
No, that'll be 6 years ago. The treasure. This is where you go.
Mhm. All right, anything
All right.
else before we call it quit?
I don't think so.
Thank you,
Super.
thank you, guys.
Good
Thanks.
job.
Guys, you okay with the schedule?
Oh, did you get the schedule?
Yeah,
Yeah.
We're good.
yeah. I'll mention something to Megan and see if she wants to jump in too.
Okay, sure.
Right.
Perfect.
Sounds good. Have a good day, fellas.
Good day.
See.